What a challenge, talking after two wonderful speakers and being between you and the lunch break. That's a really big challenge. But I'd like to start by thanking the organizers for giving me this wonderful opportunity to participate in this great conference. And I'm going to talk about a topic that's so dear to my heart, and it keeps me very busy on a daily basis because the number of consultations I get over the phone regarding vaccines maybe outweigh any other number of consultations that I get. And with that being said, my first case scenario is going to be vaccine refusals. Among the audience, who has encountered parents? So who among the audience have encountered parents refusing vaccines with the raise of hand? Wow, okay. And that brings me to the next picture. This is my dad, my source of pride, my first teacher in pediatrics. And the reason why I put this picture, not because I'm so proud of him and I like to take him everywhere I go, as much as he used to take me everywhere he used to go. But when I first joined my residency program in the United States in 2000, and I came back to Al Ain Hospital, I was trained in Al Ain Hospital for 6 years before going to the States. And in my first visit back, I was very excited. I wanted to present something. So Dad said, okay, we'll give you the grand round. You go and present something. And he said, what are you going to talk about? I said, I have a surprise. And I refused to tell him what I'm going to talk about. And what I talked about at that time was vaccine refusal in the United States. It was, just at the beginning of it. And right now, about 5 to 7% of parents refuse vaccines in North America. So the moment I finished the presentation, I went to my dad and I said, how did I do? And he was, Hossam, very bad choice. I was like, what? He said, very bad choice. It was boring, totally non-relevant, and we have nothing to do with this. Now, that was in 2000. Just 18 years ago, we did not encounter anybody in UAE who would refuse vaccines. And now, almost everybody in the audience raised their hands. It is a real challenge, and we have to find a way to combat that. I would need one full workshop, not a lecture, one full workshop to share with you the armamentarium that you should have to combat the vaccine refusals. But I feel obliged to share a few slides with you. This is the bare minimum that you should share with every patient who comes to your office refusing vaccines. Let's see the facts. In the United States, they looked at what's the best thing they have done to keep human healthy in the United States. They have done some amazing measures, and this is the list of them. But whenever they audited, they find that vaccines really is the best thing they have done to their people. Between 1900 and 1998, a span of 1 century, vaccine was number one. And the 1 decade that came after that, vaccine continued to be number one in saving lives. And I'm a little bit biased toward ID, but when you look at the 10 things that saved more people in the United States, you find that at least 2 of them are related to my field. So I'm very happy to be an ID person. All right. If there's nothing you're going to take from this lecture, please take a photo of this presentation or this slide. These are facts. In the left is the number of illnesses that was reported just 1 year before introducing the vaccine. And in the right is the number of same illness nowadays, now that we are vaccinating for the illness. I'm sorry, the pointer doesn't work on the screen? Okay. So as you can see in the first line, just 1 year before introducing the diphtheria vaccine, there were 21,000 reported cases, let alone the ones that are not reported. Now we see 0 diphtheria. And this is data from the United States that could be replicated in any other country that's using vaccines widely. Look at Haemophilus influenza that used to cause tons of meningitis, tons of sepsis. 1 year before introducing the vaccine, 25,000 cases reported. Few years after that, dropped down to only 200, so back and so forth. So I'm not going to spend time reading this slide, but just look at the visual impact of what the vaccines did and how much lives they have saved. Let's talk about Varicella vaccine. Look at the beauty of the curve. So we started vaccinating late in 1997, and as more and more people took the vaccine, the number of cases dropped to almost negligible numbers now in the United States. Who could argue this fact, that vaccines do work? Look at the world map with polio. We have generations now who haven't seen polio. So when you come and give them the few drops in the mouth, or you want to give them the shot in the shoulder, they start arguing with you about the vaccine because they haven't seen the paralyzed generations that we used to have before that. And nowadays, thanks to this very simple vaccine, we have only 3 countries who are suffering from polio endemic, and hopefully we can eradicate that too. So This is one reason why we should continue to vaccinate. The other reason is we are losing antibiotics, which is our main armamentarium in fighting infections. So we better prevent them before they even happen. And I'm pretty sure you've all read the statement by Alexander Fleming when he said, when he first came up to receive his award for discovering penicillin, the time may come when penicillin can be bought by anyone in the shops. Have you seen this time? This is where we are right now. Not only penicillins, you can buy third-generation cephalosporins in many places of the world without a prescription. And because of that, we are losing antibiotics. These are general facts. Almost 1/3 of patients admitted to the hospitals, they're receiving antibiotics for one reason or the other, and half of them receive either inappropriate choice, inappropriate dose, or inappropriate duration. And that's why antibiotic stewardship became a must now in all the hospitals. Our dear surgeons, I hope we don't have many of them, or I hope we have many of them among the audience. They still give patients antibiotics before surgery and after surgery, and they forget to change their scrubs when they leave the room and come back again to the OR. And they blame that for the wound infections. So there is a huge unnecessary consumption of antibiotics that's leading to complete loss of the armamentarium that we used to have to combat infections. And just look at this beautiful graph. Here I'm talking about one of the most simple organisms, which is Strep pneumo-resistant to penicillin. I'm not talking about ESBLs, I'm not talking about CRE, those big organisms. I'm talking about Strep pneumo. And look at the relation between the rise in resistance and the amount of antibiotic that's dispensed per 1,000 population. So in countries like Netherlands or Denmark, and my brother back there was trained in Netherlands, he used to call me and saying, I can't get amoxicillin. Even my pediatrician wouldn't give me amoxicillin. And that's why they have one of the lowest rates of resistance in the whole world. While when you go to countries like Portugal and France, where it's very easy to get even without a prescription, look at how the resistance rate is going. So there is no doubt that the more you use it, the more you lose it. Now, let's look at this graph and remind ourselves how much does it take in terms of money and in terms of time to produce a vaccine or a drug. And I'm going to relate to this figure in two ways. Number one, so it takes about 10 to 15 years to produce a new product and put it on the shelf. And anywhere from $2 to $0.6 billion to produce a new agent. Why is that important? It is so unfair to a vaccination company that worked their butt so hard, excuse my French, to produce a product and put it on the shelf, and someone would come half-educated and say, nope, I don't want to give that shot to my kid, it's not safe. It has been 15 years of work and $2.5 billion of intense research to produce that product. So that's one way I relate to this figure. The other way I relate to this figure is the fact that no more companies are interested in producing antibiotics. Because if I'm going to spend this time and this amount of money, I'm going to produce it in what we call life maintenance medication. Something for diabetes, something for depression, something for blood pressure, something that a large number of population would take. And the result is, look at the amount of antibiotics that are coming to the market. Back in the 80s, there were tons of them. Almost every month, there is like a new antibiotic coming. Between 2008 and 2002, there were two projected, and thank God they came and see the light. Ceftazolone and ceftazidime avibactam. Are there any new antibiotics coming? I'm telling you, you're not going to see anything new for the next 10 years, and even beyond. So we're really running out of antibiotics, and the way to go is antibiotic stewardship, infection control, and vaccinate, vaccinate, vaccinate. We need to prevent, because once the infection happens, our chances, our armamentarium to fight the infections are really going down. I'm so happy to join the Heart Medical Center right now, and I used to spend lots of time in my clinic in Tuam Hospital counseling parents who are anti-vaccine, sometimes 30 minutes, 40 minutes, whatever it takes, but I think it's really worth it because I think I'm saving lives. And I'm going to continue to do the same in my new position. And for those who are interested in Instagram, I have many, many videos actually combating and refuting all those theories that are anti-vaccine. Please make sure to see them, share them, consider them yours, do whatever you want just to continue the fight here against those who are anti-vaccines. So with that being said, I'm going to take you through some of the common consultations I receive, typically over the phone. So one of the typical questions is, what's the minimal interval between vaccine X and vaccine Y, vaccine X and vaccine Y? I'm going to make it very, very simple for you. You can give the vaccines at any interval, the only thing that you need to remember is MMR and varicella. Either you give them together or you space them by 1 month. For any other vaccine, there is no spacing. You could give HIB today and you could give DTaP next day or after 3 days or 4 days. There is no interval. The only interval you need to remember is MMR and varicella, either together or spaced by 1 month. Now, there is another scenario that you may not encounter here in UAE because we still don't use this vaccine. If you're going to use Minactra for a child who is 10 years or 11 years, according to the Saudi schedule, according to the Canadian schedule, and you're going to use DTaP as a booster, again, because of them, both of them carry the same conjugate, which is the diphtheria conjugate. Either you give them together or you space them by 1 month. So that's the other scenario you need to remember, DTaP and Minactra. What if my patient recently received blood product? Now, this is a very, very important one, and I wish that you can capture this picture. So there are different scenarios where you really need to consider delaying your vaccines, and by vaccine I mean MMR. So this whole table is applicable to MMR and MRV only. You don't need to delay any other vaccine related to blood products. Let's take it from down. So if you have a patient with Kawasaki disease or severe ITP where you ended up giving a high dose of immunoglobulin, MMR or MRV needs to be delayed for 11 months. If the patient received a small amount of IVIG for simple ITP, then only 8 months. What about blood products? Patient received washed RBCs, no problem. But if he received backed RBCs, which we often use, then you have to space MMR by 5 months. And I can't tell you how many times I saw this being ignored. Not because it's harmful, but the vaccine would be useless. It's going to be neutralized and the vaccine needs to be repeated. If the patient received plasma or platelet products, MMR needs to be delayed for 7 months. What about Synagis, RSV, polivizumab? Nothing. You can give it together with the vaccines on the same day. You can give it at any other interval. You don't need to delay anything. Another common example is up there, the hepatitis B prophylaxis. So if you do hepatitis B prophylaxis in the form of, and this is a very rare scenario because most of the kids who need this, they are very young at birth. But I had few scenarios where a patient got exposed to hepatitis B and he's about to get his MMR. So either you give the Hep immunoglobulin together with the MMR on the same day or you space them by 3 months. What if my patient recently exposed to a patient with active pulmonary TB and now he's due for MMR? So a typical scenario would be I would get a group of kids coming to me from a daycare or from school. They're about to get their MMR booster at 4 or 5 years. And lo and behold, they got exposed to homemade with open TB. So in this case, either you do the PBD test and you give them the MMR on the same day, or you have to delay the PPD for 6 weeks because the MMR is going to inhibit the reaction toward the PPD. So once again, if there is any kind of scenario where you have to do MMR and PPD on the same visit, either you do them together or you do the MMR and you delay the PPD for 6 weeks. Hepatitis B vaccine. I get lots of phone calls, especially with kids who are born outside the country and they come here and they're trying to catch up with the vaccines. So 2 rules to remember. The minimum interval between the doses is 2 months. So you know that you have to get 3 doses. There has to be 2 months between them. However, the third one has to be at 6 months or beyond. So if you get a child who is 1 month old, born in another country, and he's coming to you and he needs to be vaccinated, you could give him 1, 2, and 3, but you want to make sure that the third dose falls after his 6 months of life. Okay? Let's skip this. Common scenario, how to manage a baby born to hepatitis B positive mom. Everybody knows you have to give the HBEG or HBEG and the vaccine together at the same time. Now, HBEG has to be given in the first 12 hours. There is a very doubtful benefit of giving HBEG after 12 hours. So do your best to do it in the first 12 hours. And this baby needs to be tested. We need to check his hepatitis surface antigen at 9 months and 18 months to confirm negativity. And after his first birthday, we need to confirm that he reacted to the vaccine because we know about 5% of us who receive the vaccine routinely, we don't convert. and you may have to repeat the series once again. What if we don't know the status of the mom? You know, mom has just arrived to the country, she had no prenatal care, she just delivered a baby, we don't know what's going on. So if the baby is less than 2 kilograms, I have to give the HBIG immediately because I can't wait for the hepatitis surface antigen to come back for the mom. But the good news is, if the baby is more than 2 kilograms, then I could delay the HBIG up to 7 days. And this is an exception. So I can send the hepatitis B surface antigen for mom and wait for the result and act accordingly. Few scenarios with DTaP. If the patient is contraindicated to receive the DTaP, and there are only 2 contraindications to receive it, then we have to use DT. And I'm telling you, there is a little bit of difficulty of getting this. In the Emirates of Abu Dhabi, you only can get it through the preventive medicine department. And you have to call them ahead of time because they have very small stock of it. If you have a patient coming to you and his vaccination was interrupted, he did not get the hexavalent or pentavalent or DTaP on time, you don't have to repeat it, just keep continuing. What about kids who are older than 7? Once they turn 7, you can't use the DTaP anymore. So now you have to use the Tdap, the one that has a small amount of diphtheria and a small amount of acellular pertussis. Now, for the time being, the recommendation is that each one of us, everybody here among the crowd, should have received at least 1 dose of Tdap. And you don't have to repeat it unless you become pregnant. So for pregnant women, for every pregnancy, for every delivery, they need to receive a Tdap to protect themselves and protect their babies. But I'm telling you, very soon, the tetanus toxoid is going to be removed, and everybody would have to receive Tdap every 10 years. It's coming very soon. Now, this is very important. I can tell you how many times I receive kids to my clinic. The doctor would send them to my clinic and say, please manage this patient. He is contraindicated for TDAP. We cannot use it anymore. Now, remember, precautions is different than contraindications. The only 2 contraindications to give Tdap or DTaP is pure anaphylaxis, and anaphylaxis where you have to resuscitate the kid and give epinephrine. That's prophylaxis. It's not a rash, it's not redness, it's not iffy feeling. It has to be frank prophylaxis, anaphylaxis, I'm sorry. And encephalopathy within 7 days, which is by definition major change in sensorium. The child lost consciousness or was totally out of the world because of the vaccine. Only in those 2 cases, it's considered contraindicated. Everything else that we see to the right, which we see every now and then in the clinic, that's a precaution. And the difference between both is, for precaution, I have to keep the child in my clinic for 30 minutes. That's about it. It's not a contraindication, so you need to continue giving the vaccine. And believe it or not, in the most recent AAP guideline, they added the statement. They say if contraindication, even if the patient is contraindicated to receive the vaccine, consider using it. So even the contraindications are not absolute contraindications. How many of you in the audience have seen a case of neonatal pertussis in the first 2-3 months of life? Okay. Do you remember the amount of suffering that the baby had and the mom had with this kid coughing, uncontrollable in the clinic, mom is crying, doctor do something, and we go in and we can't do anything for those babies? So, would you rather deal with this or deal with a small anaphylaxis in a controlled environment where all you have to do is an epinephrine shot in the muscle? I would pick the second one. So, be more courageous in using DTaP, hexavalent, pentavalent, whatever agent you use for your patients, because the benefit far outweigh the probable harm. What about children with neurological disease? Now, we'll say if the child is established to have a neurological disease, he has SMA, he's having major hypoxic ischemic encephalopathy at birth or whatever, delay, not stop, delay the vaccination until the patient becomes static, until the case stabilizes. And the only reason we're saying this, because we don't want the parents to blame the vaccine for any further deterioration that may happen, not because of the safety of the vaccine. Polio vaccine. Maybe the only thing you need to remember from this slide is this contraindication. Any residents among the audience? Okay, for the residents among the audience, I bid you, this presentation is going to answer 2 to 3 questions in any standardized board that you would sit for. Okay, there are always questions about vaccines. And this is one common thing, contraindications to oral polio, streptomycin, polymycin, and neomycin allergy. Other contraindication is if you are dealing with an immunocompromised patient, and the list is there, I'm not going to read it. Haemophilus influenza B, it's part of the multiple vaccines that we use. The interesting thing that you need to know, if you have a child who developed meningitis before the age of 2, that meningitis doesn't give him enough protection. You have to continue to proceed with the vaccine. But if you have a child coming to you and he developed meningitis after the age of 2, you don't have to continue the vaccine. He is protected. Rota vaccine. What are the contraindications for Rota vaccine? History of intussusception, severe allergy, or if the child is having SCID, either confirmed SCID or doubted to be a SCID. So mom is saying, I lost a child to a SCID, or we have strong family history of SCID. Hold the vaccine until you clarify the situation of the patient, and try to clarify it quickly, because the first dose of Rota has to be given before 15 weeks, okay? If 15 weeks have passed, then you cannot vaccinate for Rota. The other thing, if you're using the monovalent rotavirus vaccine, be careful if the child has spina bifida or bladder extrophy, because they may have an allergic reaction to the vaccine. Can I give the vaccine to preterm babies? Absolutely yes. So whenever the preterm baby is healthy to leave the unit, that's the time to vaccinate him, even if he was 26 weeker, even if he was 27 weeker. But the question is, what if he's 28 weeker and he spent 15 weeks in the unit? So he's not discharged yet. Can I give the vaccine in the unit? Now, the current recommendation is, they did not mention anything about that. They're not encouraging or discouraging the use within the unit because of the fear of the virus spreading within the unit. However, there is a barrage of articles coming in the IDSA and ESPET showing that the vaccine is safe to be used within the hospital, because even if it gets shed in the stool, it's not contagious. And this is what I used to practice in Tuam Hospital. I used to tell people in the NICU, if a baby is going to become 15 weeks or more in the NICU, please give him the Rota vaccine on my own responsibility. I'll skip this. Okay, if I have immunocompromised sibling at home, can I still have the vaccine given to the healthy child? And the answer is yes. Yes, it's relatively a live vaccine and it could be spread in the stool, but the chances of that immunocompromised kid getting the natural infection is way much higher. There isn't a single kid who would escape Rota infection. Every child is going to get Rota infection. So for me, I'd rather him get the Rota strain that's in the vaccine rather than getting the wild one from the community. Skip this. Yeah. What about if I have a child who got admitted with confirmed case of Rota? Do I have to continue to proceed with the vaccine? And the answer is yes, because there are many, many strains out there, and you never know when is he going to get the next one. And always remember, 70% of kids younger than the age of 5 are going to get 2 episodes of Rota due to 2 different strains. So always continue your vaccination series. Varicella vaccine, the common question that I get about Varicella and MMR, for the sake of time, I'm going to combine them. So can we vaccinate pregnant women? Definitely you cannot. It's a live vaccine. It's dangerous, but try in any mom planning to deliver or to planning to conceive, to clarify her status before she becomes pregnant and vaccinate her accordingly. If you happen to see her when she's pregnant, again, try to clarify what's her status and bring her back when she comes back for the post-term visit. Catch her during that visit and give her the vaccine that she needs. What about immunocompromised patients, such as HIV? Again, if they are in severe immunodeficiency status, if their CD4 count is less than 15%, you should not. But if their CD4 count is more than 15%, they're stable, their HIV count is extremely low, the benefit of giving the vaccine far outweighs the harm, and we recommend to vaccinate them cautiously. We mentioned that. If we have a varicella outbreak, every child who received only 1 dose should get a 2nd dose, okay? Thank God, I mean, here in UAE, we give 2 doses to everybody, but what if we give the first one at 1 and we give the second one between the age of 4 and 6? But what if there is an outbreak in the school and the kids are between the age of 2 and 3? Bring them in and give them the 2nd dose immediately. Now, there is one very important hint I would like to give you. There are 2 vaccines that start working within 24 hours. So you could use them during outbreaks, and they're very effective. I just gave you one. The other one, anybody can guess? Hepatitis A, okay? So those are 2 vaccines that could be used during outbreaks, and they're very efficacious. We just talked about that. Okay. Other extreme contraindication to MMR, as we said, pregnancy and anaphylaxis to neomycin and gelatin. That's a typical board question for the residents among the audience. And long-term systemic corticosteroid, which is by definition 2 weeks or more of 2 milligram per kg of steroid or 60 milligram total. We mentioned that. Can I give the vaccine to patients with egg allergy? Yes, absolutely. It's not a contraindication anymore. And I forgot to mention something for those of you. I get phone calls about the use of MMRV. I mean, MMRV is available in private pharmacies and in some private hospitals. The current ACP and NACI recommendation is not to use it for the first encounter. So at the age of 1, we recommend not to use MMRV together. So use MMR alone and V alone. But if you want to use them together for the 4-year visit or for the 18-month visit, that's absolutely okay. So the first time they receive MMR or varicella, they have to receive it separately. So finally, these are my last 2 slides. How often can pediatricians change parents' mind? Many times, you know, my friends would talk to me and say, Hussam, you're very passionate about vaccine. You always try to change parents' mind. But let's be practical. I mean, we work in very busy offices. We see one patient every 10, 15 minutes. We really don't have time to sit and go and answer all those questions. And you know what? By the end of the day, it doesn't matter, because when they made up their mind not to vaccinate, I cannot change their mind. And I'm telling you, this is absolutely wrong. Parents do change their mind, not because I'm a magician, but because I give them facts. And the parents, they look after their kids' best interest. They're not just there to fight you or give you a hard time. They come to you with a certain conviction, and if you manage to change it, they're going to change their behavior. And one of the most beautiful studies is this one that was published in 1996. When Prevnar 7 was first introduced into the market, people used to pay $150 for it. It wasn't covered by the insurance. So they went into thousands of parents coming to their pediatricians, and they gave them a survey. And they told them there's a new vaccine coming, and you will have to pay $150 for it. It protects against strep pneumo that causes otitis media and meningitis and sepsis. Would you be interested? 15.8% said, no, we're not interested. They were very skeptical, and they have a negative attitude toward the introduction of a new vaccine. 46.9% of them were kind of, okay, we will listen to the doctor and decide. After spending the average of 8 to 10 minutes with their pediatrician, this is the result. 85% of both populations, even those who came in skeptical with negative attitude against vaccines, it took 8 to 10 minutes of sitting with a pediatrician, and they changed their mind and they vaccinated their kids out of their pocket. So what about here, where the vaccine is by the government, and we can assure the parents that the vaccines have been very well studied by the government. There is a scientific committee looking after the safety and after the efficacy, and we trust our government and we trust our societies. Trust me, our job here is way much better. Let's remember that vaccines save an average of 3 million kids per year. Make sure that you vaccinate your kids and be an advocate for vaccination. Thank you very much.
Informative.